Welcome to the deep dive. Whether you are a medical student frantically prepping for your board exams, a junior doctor reviewing core medico-legal principles before a difficult shift, or a seasoned clinician taking a moment to revisit the foundational pillars of forensic medicine, this deep dive is crafted specifically for you.
Absolutely. The material we are covering today is universally relevant across the medical spectrum, but it requires a very specific analytical lens.
Yeah, we are going to build clear conceptual frameworks today, connecting the mechanism of an injury to the interpretation of the toxicological findings, and finally to the overarching medico-legal implication.
Because in forensic practice, understanding the how is just as critical as identifying the what.
Exactly. So today's topic focuses entirely on medicinal poisons. The overarching theme we're exploring is when treatment becomes toxicity.
It is a fascinating area.
It really is. We are investigating the central paradox that substances designed and prescribed entirely to heal can become lethal weapons of harm.
Right. And this can manifest through an accidental therapeutic miscalculation, a tragic misuse, a cascade of unforeseen drug interactions, or, in the darkest forensic cases, pure malice.
It requires a profound shift in perspective, doesn't it? I mean, in clinical medicine, a clinician views a pill bottle as a therapeutic tool.
But in forensic medicine, therapeutic intent does not eliminate toxic potential.
Right.
The core principle we will return to repeatedly throughout this analysis is this dose and mechanism determine harm. The line between a therapeutic intervention and a fatal poisoning is often merely a matter of milligrams.
Or a subtle shift in metabolic clearance.
Precisely.
Now, before we get into the clinical and forensic details, I need to state our mission and give our mandatory disclaimer.
Always important.
Yes. This entire deep dive is based strictly on Chapter 25 of Simpson's Forensic Medicine. This is a conceptual deep dive designed to support your reading.
It will build those frameworks and make the material memorable, giving you the physiological and pathological anchors you need.
But, and I cannot stress this enough, it is not a regurgitation of the text, and it absolutely does not replace reading the actual chapter in Simpson's.
Use this as a companion guide to your own rigorous study of the primary text. We are here to focus on reasoning rather than rote memorization of lists.
We want to encourage the integration of pathology, physiology, and law. The textbook remains your primary authority, especially when it comes to specific reference ranges and evolving legal statutes.
Our goal is to ensure that when you read those ranges, you understand the physiological cascade that produces them.
Okay, with that established, let me give you a hook for what is coming up over the next hour. We are going to explore the dual nature of modern pharmacological agents.
The shared pathways.
Exactly. We will look at how the active ingredients in common over-the-counter cough syrups utilize the exact same receptors in the central nervous system as heavy dissociative anesthetics.
That always surprises people.
It is wild. And later, we are going to dive into the reality of forensically invisible cardiac deaths.
Where a widely prescribed therapeutic drug stops a heart dead, but leaves absolutely zero structural trace on the autopsy table.
We are dealing with complex pharmacology, highly variable individual tolerance, and pathological findings that are often incredibly subtle.
The forensic pathologist has to meticulously differentiate between therapeutic, toxic, and fatal concentrations.
All while understanding how post-mortem drug redistribution severely complicates that interpretation. So let's unpack the foundation of this, starting with receptors and shared pathways.
The core information from Chapter 25 is that large doses of virtually any medicine can cause cardiotoxicity or neurotoxicity.
But from a forensic standpoint, the mechanism is what dictates the investigation. When toxicity occurs, it is frequently because the medicine shares the ability to stimulate the exact same set of receptors as abused illicit drugs.
And that shared pathway severely complicates the medico-legal interpretation.
How so?
Well, we tend to categorize drugs socially and legally, right? Clinicians and law enforcement think in terms of prescription painkillers versus illicit street drugs.
Right, the legal classification.
But at the molecular level, neurochemistry is totally blind to legal classifications. The receptors in the central nervous system are simply responding to molecular conformations.
If the molecular key fits the lock, the physiological cascade is initiated.
Exactly. Regardless of whether that key was synthesized in a sterile pharmaceutical facility or a clandestine lab.
Okay, let's look at the mu receptors to ground this concept. We have prescription analgesics like oxycodone and hydrocodone
They are heavily regulated, prescribed by physicians, and dispensed by pharmacists.
But they bind to the exact same mu receptors as illicit heroin or morphine.
And this molecular reality dictates the entire forensic presentation. Because the receptor target is identical, the mechanism of death is identical.
So a fatal overdose of hydrocodone will present with the same profound central nervous system depression.
The same suppression of the respiratory drive in the brainstem, and the same terminal hypoxia as a massive heroin overdose.
The forensic pathologist is looking at a shared pathway of injury. The gross anatomical findings at autopsy, pulmonary edema, cerebral hypoxia, maybe a distended bladder from urinary retention, they are entirely non-specific.
They simply indicate a terminal hypoxic event secondary to respiratory failure.
So if the macroscopic findings at autopsy are identical, the burden of differentiation falls entirely on the toxicological analysis and the scene investigation.
That is exactly it. The toxicology report will identify the specific parent compound and its metabolites, distinguishing hydrocodone from diacetylmorphine.
But the scene investigation and the review of the prescription history are what allow the forensic pathologist to determine the manner of death.
Yes. A lethal concentration of oxycodone in a patient with a valid escalating prescription for chronic pain requires a very different medico-legal interpretation than the same concentration in an individual with no prescription and a history of illicit substance use.
The mechanism of death is the same.
But the manner of death could be therapeutic misadventure, suicide, or accident.
Which brings us to another fascinating parallel Simpson's highlights regarding shared pathways: the NMDA receptors.
This is a great example.
The text points out that antitussive cough suppressants, specifically dextromethorphan, which is ubiquitous in over-the-counter cold medicines, bind to the N-methyldaspartate, or NMDA, receptors.
And these are the exact same set of receptors targeted by dissociative anesthetics.
Explain the NMDA receptor's role normally.
The NMDA receptor is a critical component of the brain's excitatory pathway, primarily interacting with the neurotransmitter glutamate. When a pharmacological agent blocks or alters this receptor, it disrupts the normal flow of sensory information to the conscious mind,
causing profound dissociation.
Right. Dissociative anesthetics like ketamine or PCP leverage this mechanism for surgical or recreational purposes.
But at therapeutic doses, dextromethorphan simply suppresses the cough reflex in the medullary cough center.
Exactly. It barely touches the threshold required for central dissociation.
But in massive overdoses, which the literature shows we see in both recreational misuse and accidental pediatric poisonings, the presentation shifts radically.
It does. In massive overdoses, the sheer volume of dextromethorphan molecules flooding the central nervous system overwhelms the medullary targets.
It begins locking into that exact same NMDA receptor set across the cortex,
triggering the same dissociative neurotoxic cascade as a PCP overdose. The patient presents with profound agitation, hallucinations, tachycardia, and potentially seizures.
So the ER physician or the forensic pathologist reviewing the clinical notes is looking at a presentation that mimics a Schedule I hallucinogen.
But the toxicological source is an over-the-counter syrup.
It all comes back to the dose and the specific receptor affinity. Now let's explore what happens when we start combining these agents, the synergistic trap.
This is where things get incredibly dangerous.
Simpson specifically highlights the benzodiazepine family alprazolam, clonazepam, diazepam, zolpidem. These drugs bind to the benzodiazepine receptor, which is an allosteric site located on the GABA-A receptor.
The GABA-A receptor is the primary inhibitory workhorse in the mammalian central nervous system.
Walk us through how that works.
When the endogenous neurotransmitter GABA binds to it, it triggers a conformational change that opens a central chloride channel. Negatively charged chloride ions flood into the intracellular space of the neuron, hyperpolarizing the membrane,
making it significantly more difficult for that neuron to generate an action potential.
Precisely. Benzodiazepines do not directly open this channel, though. Rather, they act as positive allosteric modulators.
Meaning they alter the receptor's shape so that when GABA binds, the chloride channel opens more frequently,
massively enhancing the inhibitory effect.
They globally dampen neuronal firing, which is why they are highly effective for managing severe anxiety, terminating status epilepticus, or inducing sleep.
But the forensic trap, the medico-legal nightmare discussed in the text, arises when these agents are combined with opiates.
Because opiates are actively hitting the mu receptors in the brainstem to depress the respiratory drive.
Simultaneously, benzodiazepines are hitting the GABA-A receptors to globally inhibit neuronal firing across the entire central nervous system.
Including the very centers trying to maintain that respiratory drive.
When combined, they act synergistically. It is a multiplicative physiological depression.
This is a classic textbook forensic pattern of mixed ingestion, and the complexity lies in the interpretation of the toxicological concentrations.
It really does. A toxicology report in a mixed ingestion case is rarely straightforward.
You might see a concentration of diazepam and a concentration of oxycodone that, if taken independently, would merely be considered toxic or even fall within the high end of a therapeutic reference range.
A novice reviewer might look at those numbers and assume neither drug was present in a universally fatal quantity.
But the forensic pathologist must interpret these findings in concert. The cause of death is the combined synergistic respiratory depression.
And from a medico-legal documentation standpoint, differentiating between a therapeutic error, an intentional self-harm overdose, and a tragic accidental synergy requires immense discipline.
The determination relies heavily on the prescription history, the pill counts at the scene, and the clinical context prior to death.
Did the patient have escalating tolerance? Was there a recent change in the dosage of one medication without adjusting the other?
The pathologist has to construct a timeline of ingestion to rule out intentional massive overdose and accurately classify the death as an accidental synergistic toxicity.
Speaking of clinical context and the interpretation of drug levels, Simpsons highlights a counterintuitive medico-legal scenario regarding barbiturates.
Right. Historically, barbiturates were a primary culprit in fatal intentional overdoses due to their narrow therapeutic index.
But today, the text notes they are rarely the cause of death by excess.
Instead, especially in epileptic patients, death is often caused by the absolute absence of the drug.
This phenomenon highlights the profound physiological dependence created by certain classes of drugs. In the context of epilepsy, this is known as SUDE.
Sudden unexpected death in epilepsy.
Exactly. When an epileptic patient is maintained on a barbiturate regimen, their baseline neuronal excitability is artificially and continuously suppressed.
The neurochemistry adapts to this constant inhibitory presence.
So if that medication is abruptly stopped, whether due to noncompliance, a lack of access, or an administrative error in a care facility, the brain doesn't just return to normal.
It experiences a massive catastrophic rebound of electrical activity.
The sudden removal of the inhibitory constraint triggers a profound excitatory storm. This withdrawal precipitates severe, uncontrolled, continuous seizure status epilepticus.
The sustained muscular contractions and the massive metabolic demand of the seizing brain lead to rapid fatal hypoxia.
Severe cardiac arrhythmias, and ultimately death.
Forensically, this completely flips the traditional script of a poisoning investigation. You are not looking for a lethal peak on the mass spectrometry readout.
No, you are looking for a void. You are looking for an unexpectedly low, subtherapeutic, or entirely absent level of the barbiturate in the postmortem blood of a patient whose medical history mandated its continuous presence.
The lethal harm was caused by the cessation of the therapeutic agent.
The medico-legal investigation then shifts from determining what poison killed the patient to determining why the life-sustaining medication was withheld or missed.
Which can have massive implications for medical malpractice or institutional negligence.
Absolutely.
We've just looked at how combined medications can slowly shut down the respiratory drive, or how the absence of a depressant can trigger fatal seizures. But there's a completely opposite forensic scenario detailed in Chapter 25.
Where modern pharmacology pushes the nerve system into an absolute lethal overdrive.
Let's transition to serotonin syndrome.
Serotonin syndrome is a vital clinical and forensic entity. First recognized in 1991 by Harvey Sternbach, it is an entirely clinical diagnosis caused by excessive serotonin activity throughout the central and peripheral nervous systems.
Strictly secondary to medication exposure.
Correct.
The underlying mechanism here is critical for understanding the clinical presentation. Simpsons breaks this down using second- and third-generation antidepressants, such as SSRIs and SNRIs.
These medications are specifically engineered to alter synaptic dynamics. To grasp the pathology, we have to look at the synaptic cleft.
Walk us through it.
The presynaptic neuron releases serotonin into the cleft to bind with the receptors on the postsynaptic neuron, propagating the signal. In a normal physiological state, the presynaptic neuron utilizes a reuptake pump to pull the serotonin back out of the cleft.
Terminating the signal and recycling the neurotransmitter?
Right. Now, SSRIs block that specific reuptake pump. They selectively inhibit the reuptake mechanism.
Which is highly therapeutic for a patient with major depressive disorder because it allows serotonin to linger in the synaptic cleft for a longer duration,
Enhancing and prolonging mood-regulating signaling. But in the pathology of serotonin syndrome, this therapeutic mechanism spirals into a massive, uncontrolled cascade,
The synaptic clefts are continuously flooded with serotonin.
leading to extreme hyperstimulation of the 5-HT receptors, not just in the brain, but across the entire peripheral nervous system.
Simpsons points out a striking comparison here. The textbook explicitly states that this underlying mechanism, blocking reuptake and flooding the synapse with monoamines, is the exact same underlying mechanism as cocaine toxicity.
Yes. Cocaine is a potent, non-selective reuptake inhibitor, affecting dopamine, norepinephrine, and serotonin. When a patient presents in full-blown serotonin syndrome, their physiological state is profoundly hyperaroused.
They are locked in a state of extreme sympathetic overdrive.
That physiologically mirrors a massive central nervous stimulant overdose.
Let's visualize what this actually looks like. Instead of just listing the symptoms from Table 25.1, imagine a patient being rushed into the ER.
Okay.
Simpsons outlines a clinical triad for pattern recognition, mental status changes, autonomic instability, and neuromuscular abnormalities. Walk us through the clinical progression from mild to severe.
Recognizing the spectrum is essential because the progression can be incredibly rapid, often escalating from mild to life-threatening within 12 hours.
Let's start with a mild presentation.
In a mild presentation, the neuromuscular excitation is subtle but distinct. You might observe hyperreflexia upon striking the patellar tendon, a fine resting tremor, or myoclonus.
What about their mental status?
The patient's mental status is typically characterized by acute anxiety, restlessness, and insomnia. Autonomically, they're experiencing diaphoresis, their pupils are dilated, and they exhibit persistent tachycardia.
It could easily be misdiagnosed as severe anxiety, a panic attack, or mild withdrawal from alcohol or sedatives.
Very easily. But if the serotonergic burden continues, it escalates to a moderate presentation.
And what does that look like?
In a moderate case, the neuromuscular signs become undeniable. The patient will likely exhibit opsoclonus rapid, irregular, conjugate eye movements. And crucially, you will see spontaneous or inducible clonus.
Inducible clonus being.
If the attending physician takes the patient's foot and abruptly dorsiflexes it, pushing it upward toward the shin, and holds it under tension, the foot will begin to rhythmically and forcefully beat against the physician's hand.
That clonus is a hallmark of profound upper motor neuron hyperexcitability.
Exactly. Mentally, the anxiety transitions into severe agitation. The autonomic instability manifests as marked hypertension, hyperactive bowel sounds often accompanied by diarrhea, and hyperthermia.
Though typically remaining below 40 degrees Celsius at this moderate stage.
Yes. But if aggressive clinical intervention is not initiated, the patient crosses the threshold into severe serotonin syndrome, which is an absolute life-threatening emergency.
The severe category is a catastrophic physiological collapse.
The hyperreflexia and clonus give way to diffuse lead pipe rigidity. The musculature is locked in intense, unyielding contraction.
And this rigidity, particularly in the chest wall, can lead directly to acute respiratory failure.
The patient may also experience generalized tonic-clonic seizures. The mental status degrades from agitation into a deep coma, florid delirium, or profound confusion.
And the hyperthermia becomes a central driver of mortality.
The core body temperature surges past 40 degrees Celsius, driven by the intense, continuous muscular contractions. This extreme hyperthermia, combined with the rigidity, causes massive cellular breakdown in the skeletal muscle.
Rhabdomyolysis.
Yes. The destruction of muscle tissue floods the bloodstream with myoglobin, which rapidly precipitates in the renal tubules, causing acute oliguric renal failure.
Furthermore, the intense physiological stress and thermal injury to the vascular endothelium trigger disseminated intravascular coagulation.
DIC. The patient's coagulation cascade goes haywire, leading to simultaneous widespread microvascular clotting and massive internal hemorrhage.
Without immediate paralysis, intubation, and aggressive cooling, the mortality rate is exceptionally high.
From a forensic perspective, this presents a monumental diagnostic challenge. Simpsons is very clear. Serotonin syndrome is a purely clinical diagnosis.
There is no single toxicological blood test that a pathologist can order to definitively prove the syndrome occurred.
Right. The laboratory abnormalities you might find at autopsy or in the perimortem blood draws metabolic acidosis, elevated creatinine, massive levels of creatine kinase, myoglobinuria, they are entirely nonspecific.
They indicate that the body underwent extreme physiological stress, hypoxia, and muscle breakdown.
But they do not identify the catalyst for that breakdown. The precise diagnosis relies absolutely on the clinical criteria documented while the patient was still alive.
The textbook details two diagnostic frameworks used to lock this down: the Sternbach criteria and the Hunter criteria. Let's examine how a forensic pathologist would use these criteria when reviewing the medical records of a deceased patient.
The Sternbach criteria, developed by the physician who first defined the syndrome, requires several foundational elements. The medical record must confirm the patient was administered a serotonergic agent.
The pathologist must rule out other potential causes for the symptoms, such as an active infection causing the fever.
Crucially, they must confirm the patient had not recently received a neuroleptic agent.
To definitively rule out neuroleptic malignant syndrome,
Exactly, which is a distinct pathological entity caused by dopamine antagonism that presents with similar rigidity and hyperthermia.
once those foundational elements are met, Sternbach requires the documentation of 3 specific symptoms from a broad list.
Including mental status changes, agitation, hyperreflexia myoclonus, diaphoresis, shivering, tremor, diarrhea, incoordination, or fever.
But Simpson's explicitly notes that the Hunter criteria is currently considered more specific and more sensitive than Sternbach.
The Hunter criteria shifts the focus away from the broad, overlapping autonomic and mental status symptoms and heavily weights the unique neuromuscular findings.
For a diagnosis under Hunter, the patient must have been exposed to a serotonergic agent, and then they only need one of a very specific set of neuromuscular combinations documented in the chart.
Such as the presence of spontaneous clonus,
Or inducible clonus combined with either agitation or diaphoresis.
or ocular clonus combined with agitation or diaphoresis, or any form of clonus combined with hypertonia and hyperthermia.
Hunter criteria recognizes that clonus, in the setting of serotonergic drug use, is the absolute hallmark of the toxicity.
This highlights the immense reliance forensic medicine places on clinical documentation. If a patient dies of suspected serotonin syndrome, the forensic pathologist is scrutinizing the ER notes.
Did the attending physician specifically test for and document inducible clonus? Did they note the opsoclonus?
Because on the autopsy table, hyperreflexia, clonus, and rigidity are completely extinguished. The clinical notes become the primary forensic evidence.
The pathologist can document the gross findings of renal failure. They can observe the histological evidence of DIC, and the toxicology report will confirm the presence and concentration of the serotonergic agents in the postmortem blood.
But to definitively establish the mechanism of death as serotonin syndrome on the death certificate, they must synthesize those postmortem findings with the antemortem clinical presentation.
Let's look at the culprit drugs listed in box 25.1. I'm looking at this extensive list, and it's striking how many unexpected triggers there are. It's not just a matter of a patient intentionally taking a massive overdose of their prescribed SSRI.
No, while a single-agent overdose can certainly precipitate the syndrome, the most severe and rapidly fatal cases often arise from mixed ingestions or inadvertent drug interactions.
We expect to see the standard psychiatric medications, SSRIs, tricyclic antidepressants, SNRIs, and MAOIs.
The text highlights an extreme danger, specifically regarding monoamine oxidase inhibitors, or MAOIs.
Why is this class particularly lethal when combined with other agents?
Monoamine oxidase is the primary enzyme responsible for degrading and clearing serotonin from the synaptic cleft and the intracellular space. An MAOI completely inhibits this essential cleanup mechanism.
If a patient on an MAOI is subsequently exposed to another serotonergic drug, such as an SSRI that blocks reuptake, or a drug like MDMA that triggers a massive vesicular release of serotonin, you create an insurmountable neurochemical crisis.
The brain is violently flooding the synapses with serotonin, and the singular enzyme designed to metabolize it is functionally disabled.
Simpson specifically warns against combining MAOIs with meperidine, dextromethorphan, SSRIs, or MDMA.
Noting these combinations are highly associated with the most severe fatal presentations.
Beyond the classic antidepressants, what are some of the unexpected triggers that a clinician or pathologist needs to have on their radar?
Narcotic analgesics are a major pitfall. Drugs like buprenorphine, fentanyl, methadone, and tramadol possess significant serotonergic activity alongside their mu receptor affinity.
Migraine treatments, specifically the triptan class, are inherently risky because they function as direct agonists at the type 1 serotonin receptors.
Stimulants like cocaine, amphetamines, and methylphenidate aggressively drive serotonin release. Psychedelics like LSD and MDMA are direct serotonergic modulators.
And then there is the miscellaneous category, which seems to be where the most tragic, innocent therapeutic errors occur.
Chlorpheniramine, a widely available over-the-counter antihistamine, has serotonergic properties. Dextromethorphan, which we discussed earlier in the context of NMDA receptors, is a potent serotonin reuptake inhibitor.
We also see cases involving lithium and atypical antipsychotics like olanzapine and risperidone.
The medico-legal implication here is profound. A patient fighting a severe upper respiratory infection might take an over-the-counter cough medicine containing dextromethorphan.
And an antihistamine containing chlorpheniramine while maintaining their daily prescribed dose of an SSRI for depression.
That seemingly innocuous combination of treatments can trigger a fatal cascade that clinically mimics a massive cocaine overdose.
It requires the forensic investigator to look far beyond the prescription pad. They must investigate the medicine cabinet, the over-the-counter access, and interpret the subsequent toxicological findings through the lens of highly complex neuropharmacology and receptor interaction.
So we have cases where the clinical presentation prior to death provides the vital clues, because the physical evidence of rigidity and clonus fades.
But what happens when there is no clinical presentation, no prolonged hospitalization, and absolutely zero structural evidence left behind at autopsy?
This leads us to body section 3 QT interval prolongation, the forensically invisible threat.
This specific area of forensic medicine has undergone a radical revolution over the last 3 decades. We are discussing primary arrhythmia syndromes, specifically ion channelopathies.
Advances in molecular genetics have illuminated how minute alterations in the genes coding for membrane proteins, specifically the ion channels responsible for orchestrating cardiac action potentials, can precipitate sudden, lethal electrical storms in a structurally perfect heart.
To understand the pathology and the forensic dilemma, we have to establish the physiological baseline. Simpson's provides a clear visual description of the normal electrocardiogram in Figure 25.1, the classic PQRS T-wave morphology.
The ECG is the macroscopic map of microscopic electrical activity. The P wave represents the depolarization of the atria, the electrical signal that initiates the heartbeat.
The QRS complex represents the massive, rapid depolarization of the ventricles, which triggers the main mechanical pumping action of the heart.
But for our forensic discussion today, we are hyper-focused on the QT interval. This interval extends from the very onset of the Q wave to the absolute end of the T wave.
What specific cellular event does that interval represent in the myocardium?
It represents the complete repolarization of the ventricular cardiomyocytes. After the ventricles have contracted, the individual muscle cells must electronically reset themselves.
They have to reestablish their resting membrane potential so they are primed and ready to fire for the next beat.
That intricate resetting process is repolarization. Simpson's establishes the critical physiological baseline. The normal rate-adjusted length for the QT interval is less than 440 milliseconds.
It's less than half a second for the entire ventricular mass to reset.
Precisely. If that repolarization process is delayed, if the QT interval is pathologically prolonged beyond that threshold, it creates a highly unstable window of electrical vulnerability across the myocardium.
This is the lethal mechanism. A prolonged QT interval heavily favors the spontaneous generation of a very specific, chaotic form of polymorphic ventricular tachycardia.
It is known as torsade des pointes, twisting of the points. The terminology describes the distinct morphological appearance on the ECG tracing, where the QRS complexes appear to continuously twist around the isoelectric baseline, growing larger and smaller in a sinusoidal pattern.
Hemodynamically, it is catastrophic. It is a rapid, asynchronous rhythm where the ventricles are essentially quivering rather than effectively pumping blood. The cardiac output drops to near zero.
If the rhythm does not spontaneously revert to normal, or if the patient is not immediately defibrillated, torsade des pointes rapidly degenerates into terminal ventricular fibrillation and sudden cardiac death.
Simpson's divides long QT syndrome, or LQTS, into 2 distinct etiological categories, inherited and acquired. Let's briefly touch on the inherited form.
Inherited LQTS is rooted in genetic aberrations. Current research has identified mutations in over 10 different genes responsible for constructing these delicate ion channels.
The insidious nature of the inherited form is that an individual can possess a perfectly normal-appearing baseline ECG for decades. However, they carry the silent mutation.
A sudden physiological stress, A surge of catecholamines from an alarm clock, diving into cold water, or intense exercise causes that structurally vulnerable channel to fail, pathologically lengthening the QT interval and triggering the fatal arrhythmia.
Postmortem diagnosis of the inherited form relies entirely on molecular autopsy techniques, specifically DNA resequencing of the deceased's tissue.
But the textbook emphasizes that the acquired form of this disorder, specifically drug-induced long QT syndrome, is vastly more common than the heritable form.
Acquired LQTS is a pure pharmacological phenomenon, and the primary battleground for this interaction is a very specific microscopic structure known as the HERG channel. HERG.
The human ether-agogo-related gene channel, which functions as the rapid-delayed repolarizing potassium channel.
Let's paint a visual of this structure for you based on the computer rendering provided in Figure 25.2 of the text. Imagine a complex transmembrane cylinder constructed of spiraling blue helices. This channel spans the outer membrane of the cardiomyocyte.
During the critical repolarization phase of the cardiac cycle, after the cell has fully contracted, these specific potassium channels undergo a conformational shift to open.
Positively charged potassium ions must rapidly flow out of the intracellular space through this channel. It is this rapid loss of positive charge that resets the interior of the cell to its resting negative state.
The HERG channel is the primary conduit for this essential outward current.
The computer rendering in Simpsons shows a molecule of an experimental antiarrhythmic drug docked perfectly inside the central cavity of those blue helices. It illustrates a physical blockade.
The pharmacological agent physically lodges within the inner pore of the HERG channel. It acts exactly like a cork in a bottle. Because the channel is blocked, the potassium ions cannot escape the cell at the required rate.
The outward current is drastically slowed down. Consequently, the repolarization phase is artificially extended.
On the macroscopic ECG, the T wave stretches out, and the QT interval prolongs well past the 440 millisecond safety threshold. The myocardium is now profoundly vulnerable to Torsades de Pointes.
And the risk is compounded by individual variability. Some patients carry subtle, subclinical mutations in their HERG genes.
These variants don't cause inherited LQPS on their own, but they alter the shape of the channel just enough to make it vastly more susceptible to being blocked by these specific drugs.
It's a fatal intersection of genetic predisposition and a pharmacological trigger.
This mechanism presents one of the most formidable diagnostic challenges in the entire field of forensic pathology. Consider the practical scenario. A patient collapses suddenly at home and cannot be resuscitated. They are brought to the morgue.
The forensic pathologist performs a complete autopsy. They open the chest, extract the heart, and perform a meticulous gross and histological examination.
The coronary arteries are widely patent with no atherosclerosis. The ventricular walls are of normal thickness. The valves are pristine. There is no evidence of ischemia, infarction, or cardiomyopathy.
The heart is structurally flawless.
It is morphologically normal. Furthermore, a routine post-mortem toxicology screen will simply quantify the concentration of a drug in the peripheral blood. The mass spectrometer will not reveal whether that specific drug molecule interacted with the HERG channels prior to death.
The toxicology report cannot definitively prove that a prolonged QT interval occurred, nor can it prove that Torsades de Pointes was the terminal rhythm.
The electrical storm leaves no physical wreckage behind. It is forensically invisible.
In the face of a completely negative autopsy and an ambiguous toxicology report, how does a forensic pathologist arrive at a defensible cause of death?
Simpsons dictates that in these cases, a forensic psychological autopsy, a deep dive into the medical and prescription history, is absolutely mandatory. The pathologist must scour the clinical records.
Did the patient have prior routine ECGs that demonstrated a borderline or prolonged QT interval? Were they recently prescribed a new medication recognized as a potent HERG channel blocker?
Did they recently start taking a drug that inhibits the hepatic cytochrome P450 enzymes, thereby accidentally spiking the blood concentration of a HERG blocking drug they were already taking?
Even with an exhaustive review, the text admits that a definitive, irrefutable diagnosis may be impossible to achieve post-mortem.
It requires immense medico-legal discipline. The pathologist cannot overstate the structural findings. They will frequently have to formulate a death certificate that lists the primary cause as sudden cardiac death in a morphologically normal heart.
While listing the presence of the proarrhythmic drug in the toxicology report as a significant contributing factor, based entirely on circumstantial clinical history and established pharmacological mechanisms.
Let's review the drug profile associated with this phenomenon. Box 25.2 in the text provides an extensive list of medications known to cause QT prolongation.
Simpson specifically notes that methadone is perhaps the most notorious and frequently encountered culprit in forensic practice.
Methadone is utilized globally for the management of severe chronic pain and as maintenance therapy for opioid use disorder. Its propensity to significantly block the HERG channel is a major, well-documented clinical concern that necessitates baseline and continuous follow-up ECG monitoring.
If a patient on high-dose methadone dies suddenly with no structural heart disease, acquired LQTS must be at the top of the differential diagnosis.
But looking at the rest of the list, the irony is profound. Many of the most potent HERG blockers are literally classified as antiarrhythmics. Drugs like amiodarone, disopyramide, procainamide, quinidine, and sotalol.
It perfectly encapsulates the overarching theme of this deep dive. These medications are specifically engineered and prescribed to suppress or correct abnormal, chaotic heart rhythms.
However, because their fundamental mechanism of action involves altering ion channel dynamics across the myocardium, they carry the inherent paradoxical risk of precipitating a fatal, acquired, prolonged QT rhythm.
The treatment directly initiates the toxicity. The list of culprits extends far beyond cardiac medications. It includes broad classes of commonly prescribed drugs.
Macrolide antibiotics like erythromycin and clarithromycin. A wide array of antipsychotics, including haloperidol, pimozide, and thiordazine. Antihistamines such as estomazole and terfenadine.
Simpson notes that the compendium of drugs recognized to interact with the HERG channel is continuously expanding as pharmacovigilance improves.
To summarize the forensic approach to QT prolongation, when the physical pathology is invisible, the interpretation relies entirely on understanding the electrical timeline and meticulously reconstructing the pharmacological history.
But as we move to our final section, we are going to examine substances where the forensic investigation requires looking far beyond the history, down to the highly unique structural biology of the molecules themselves.
Let's move into Body Section 4. We are looking at two highly unique agents, lithium and insulin. Let's begin with lithium.
Lithium is a fascinating pharmacological outlier. It is a simple elemental ion, essentially functioning similarly to sodium or potassium within the body's fluid compartments. It is utilized primarily as a potent mood stabilizer in the long-term management of bipolar disorder.
But its forensic profile is unique because, unlike benzodiazepines or opiates, lithium is completely devoid of acute psychoactive effects in a neurotypical individual.
If a person without bipolar disorder ingested a standard therapeutic dose of lithium, they would not experience sedation, euphoria, or stimulation.
And despite decades of widespread clinical use, Simpson states that its exact mode of action remains largely unknown.
It remains a complex neurochemical mystery. The text indicates there is evidence suggesting an excitatory neurotransmitter might be involved in its regulatory effect, and there are robust theories that lithium actually permeates the intracellular space and alters gene expression at the cellular level,
stabilizing neuronal membranes over time. Because it is an elemental ion, it does not undergo complex hepatic metabolism. It simply distributes throughout the body water and is cleared by the kidneys.
How does the toxicity of such a simple element present clinically and forensically?
The pattern and timeline of exposure are critical for diagnosing and interpreting lithium toxicity. The textbook emphasizes that chronic poisoning, where the levels slowly accumulate over weeks or months, is characteristically associated with significantly greater morbidity and mortality than a sudden massive acute ingestion.
Why is chronic accumulation more dangerous than a sudden overdose?
It relates to the volume of distribution and intracellular uptake. In a sudden acute overdose, the lithium floods the extracellular fluid and the blood plasma, resulting in a very high serum concentration on a lab test.
However, it takes substantial time for the lithium ion to cross the blood-brain barrier and penetrate the intracellular space of the neurons where the profound neurotoxicity occurs.
Therefore, an acute ingestion might show a massive blood level, but present with relatively mild early symptoms.
But in chronic toxicity?
In chronic toxicity, perhaps due to a declining glomerular filtration rate in an elderly patient or concurrent use of NSAIDs or diuretics that impair lithium clearance, the ion has had weeks to slowly, insidiously saturate the intracellular compartments of the central nervous system.
The serum blood level might appear only slightly elevated above the therapeutic range, but the brain is completely saturated.
This chronic accumulation manifests as severe, rapid-onset neurotoxicity, coarse tremors, profound confusion, ataxia, choreoathetosis, seizures, and eventually an irreversible coma.
Simpsons also notes a specific cardiac finding associated with lithium toxicity.
Yes, delayed cardiotoxicity is a hallmark. It typically manifests as a profound, treatment-resistant bradycardia, a dangerously slow heart rate, and repolarization abnormalities on the ECG.
Because the clinical signs of lithium neurotoxicity can closely mimic a stroke, severe sepsis, or meningoencephalitis, the diagnosis relies heavily on accurately measuring blood lithium concentrations.
And for the forensic pathologist, interpreting that postmortem blood level requires understanding whether they are looking at an acute spike or chronic saturation, while factoring in how the simple ion might redistribute across fluid compartments after death.
It requires synthesizing the lab value with the patient's renal history and timeline of symptoms. The number alone is insufficient. The kinetic context is everything.
Exactly.
Now we turn to what is arguably one of the most compelling and complex forensic puzzles detailed in the textbook. Insulin, the forensic nightmare.
Insulin poisoning is a heavyweight topic in forensic toxicology and pathology. We are specifically discussing the exogenous administration of insulin artificially introduced into the body from an outside source.
Simpsons notes that historically, insulin was a somewhat popular and terrifyingly effective means of homicide. While documented cases are now relatively rare, it remains a highly challenging investigation when it is suspected.
The lethal mechanism is straightforward but devastating. A massive overdose of insulin rapidly drives all available glucose out of the bloodstream and into the peripheral tissues. This causes severe, prolonged hypoglycemia.
Because the central nervous system relies almost exclusively on continuous glucose delivery for fuel, this acute deprivation causes massive, irreversible hypoxic ischemic brain damage.
The brain essentially starves to death, even while the cardiopulmonary system remains intact.
The pathological mechanism is clear, but the forensic challenge is immense. The pathologist must definitively prove that the massive amount of insulin found in the deceased's body was injected by a third party with malicious intent,
rather than produced naturally endogenously by the victim's own hyperactive pancreas.
This brings us to the C-peptide framework. To understand how a forensic pathologist solves this murder, we have to understand the physiological manufacturing process within the pancreas. Let's walk through the beta cells.
The beta cells, in the islets of Langerhans within the pancreas, are the body's insulin factories. When they synthesize insulin, they do not immediately produce it in its final, active, bioavailable form.
They manufacture a much larger inactive precursor molecule called proinsulin. You can visualize proinsulin as a long, continuous chain of amino acids.
Just before the beta cell secretes the molecule into the portal circulation, specialized enzymes cleave, or snip, that chain. They cut out a specific central section to fold and activate the functional insulin molecule.
That discarded central connecting section is known as the C-peptide fragment.
So the crucial concept here is the ratio. For every single molecule of active, natural internal insulin your body produces and secretes, it also simultaneously releases exactly one molecule of C-peptide into the bloodstream.
It is a perfect one-to-one physiological ratio. It acts almost like a receipt of endogenous production.
A one-to-one receipt is the perfect forensic analogy. Now contrast that with exogenous pharmaceutical insulin. When pharmaceutical companies manufacture synthetic insulin for the treatment of diabetes, they undergo complex purification processes.
The final product in the vial contains only the active insulin molecule required to lower blood glucose. They explicitly extract and discard the C-peptide during manufacturing.
The pharmaceutical vial contains 0 C-peptide.
This physiological difference provides the diagnostic key for the forensic pathologist investigating a suspected homicide.
If a pathologist is investigating a profound hypoglycemic death, they will order an assay to measure the concentrations of both insulin and C-peptide in the postmortem blood.
If the laboratory returns a result showing massively elevated insulin levels and the C-peptide levels are proportionally massively elevated, the pathologist knows the insulin originated from within the patient's own body.
The receipts match the product. This could point to an insulin-secreting tumor, such as an insulinoma, or a massive endogenous reaction to certain oral hypoglycemic drugs like sulfonylureas.
But the finding in a homicide is radically different.
In a homicide involving injected insulin, the laboratory results will show a glaring, impossible disparity. The victim will have astronomically high levels of active insulin alongside exceedingly low or completely absent levels of C-peptide.
That missing receipt is definitive proof. The high insulin is unreseated, proving conclusively that the massive dose originated from a pharmaceutical, vial, and exogenous injection.
It was scientifically impossible for the patient's own pancreas to have produced that insulin without the corresponding C-peptide.
It is an elegant, airtight biochemical trap for a murderer, but Simpsons highlights a massive, practical forensic pitfall that can destroy the entire case.
The fragility of the molecules involved. Active insulin is a relatively robust molecule. It remains remarkably stable in postmortem blood and tissue for a significant period.
C-peptide, however, is highly unstable. It degrades rapidly in whole blood, particularly at room temperature.
Which means the timeline and the cold chain are the most critical aspects of the investigation. If the investigator at the scene or the pathologist in the morgue suspects an insulin overdose, they must draw the peripheral blood sample immediately and ensure it is rapidly frozen.
If the specimen sits in a warm morgue or is transported without strict temperature controls, the C-peptide will completely degrade and vanish from the sample.
And if the C-peptide degrades due to improper handling, the forensic pathologist loses their 1-to-1 ratio. They lose the receipt.
They can demonstrate the high insulin, but they can no longer scientifically prove that the low C-peptide was due to an exogenous injection.
A competent defense attorney will simply argue that the C-peptide was originally present but degraded due to an incompetent postmortem chain of custody, effectively introducing reasonable doubt regarding the homicide charge.
The entire medico-legal prosecution hinges entirely on the rigorous discipline of preserving that fragile molecular ratio.
However, the textbook notes that forensic science is advancing to counter this fragility. There is now a DNA-based solution for identifying exogenous insulin.
Historically, pharmaceutical insulin was derived and purified from bovine or porcine pancreases. Today, nearly all commercial insulin is biosynthetic.
It is produced via advanced recombinant DNA technology, typically utilizing genetically modified strains of E. coli bacteria or yeast.
To alter the pharmacokinetic properties of the insulin, to make it rapid-acting or long-acting, the pharmaceutical engineers subtly alter the specific amino acid sequence of the molecule.
This bioengineered structure is slightly but distinctly different from native human insulin.
And forensic laboratories can now detect those minute engineered differences.
Using highly advanced mass spectrometry and molecular analysis techniques, toxicologists can analyze the insulin extracted from the deceased's tissue. They are no longer simply looking for the presence of insulin. They are mapping its exact structural sequence.
They can conclusively prove that the specific insulin molecule found in the victim's brain possesses the proprietary structural modifications of a specific synthetically engineered pharmaceutical brand.
They could trace the lethal molecule back to the manufacturing plant, completely bypassing the need for the fragile C-peptide ratio.
It's an incredible application of molecular pathology. Regarding the manner of death in these specific cases, Simpsons provides important sociological context. Homicides perpetrated with insulin are notoriously intimate crimes.
They are overwhelmingly carried out by a spouse, a close relative, or a medical caregiver who possesses both specialized knowledge of the drug's lethal potential and unimpeded access to both the medication and the vulnerable victim.
Though the text is also careful to recognize that suicide by insulin overdose is a well-documented phenomenon, particularly occurring among medical professionals, nurses, or diabetic patients who have ready access to the vials and understand the required lethal dosages.
Which brings us full circle to our core mandate. The forensic pathologist must distinguish between accident, intentional self-harm, and malicious homicide without resorting to speculation.
The pathologist relies on the rigid biochemical truth of the C-peptide ratio, the structural mass spectrometry analysis of the insulin molecule itself, the meticulous review of the prescription history, and the comprehensive scene investigation to build an airtight, objective, medico-legal conclusion.
We have covered an immense amount of complex pharmacological and pathological ground today.
Let's synthesize the core frameworks we built. The overarching forensic principle of Chapter 25 is that medicinal poisons completely blur the established boundary between therapy and lethality.
We examined shared receptors, where a common over-the-counter cough medicine utilizes the same pathways as PCP, and where the combination of benzodiazepines and opiates synergistically multiplies to extinguish the respiratory drive.
We explored the catastrophic synaptic overload of serotonin syndrome, where the precise mechanism intended to treat depression spirals out of control to mimic a fatal central nervous stimulant overdose.
We investigated the forensically invisible threat of acquired long QT syndrome, where a seemingly unrelated medication docks into the HERG channel, precipitating sudden cardiac death while leaving the cardiac anatomy pristine.
And finally, we decoded the complex molecular forensics of insulin homicide, contrasting the fragility of the C-peptide ratio with the undeniable proof provided by mass spectrometry of bioengineered structures.
In every single one of these scenarios, the raw toxicological data, the simple number on the lab report, is insufficient. Context, comprehensive medical history, and a deep understanding of the underlying physiological frameworks are absolutely vital for accurate medico-legal interpretation.
I want to leave you with a final thought to mull over, building on that last point about insulin and mass spectrometry. We saw how the traditional C-peptide ratio can be fragile, prone to postmortem degradation and legal challenge. But the emerging ability to routinely detect the specific bioengineered structural differences in synthetic insulin fundamentally changes the investigative paradigm.
If the forensic analysis of a suspected homicide now requires the detection of proprietary genetic engineering modifications, we are witnessing a massive, historic shift in the field. We are moving away from relying solely on macroscopic pathology, what we can observe with a naked eye or a scalpel on the autopsy table, and descending entirely to the molecular level.
As modern therapeutic medicines become increasingly targeted, highly synthetic, and heavily bioengineered, we are talking about monoclonal antibodies, personalized mRNA therapeutics, and advanced gene therapies, the future of forensic pathology will evolve.
The discipline may rely less on gross anatomical dissection and increasingly on what toxicologists can sequence with DNA analysis and structurally map with high-resolution mass spectrometry. The methodologies of the poisoners are evolving, but the scientific arsenal of the forensic pathologist is evolving just as rapidly.
A brilliant and profound thought regarding the future of the field. All right, to lock this complex knowledge in before your board exams or your next clinical shift, we are going to do our learning reinforcement. I have 5 rapid-fire, single best answer style prompts covering the major frameworks of today's deep dive. I will ask the question, pause briefly so you can lock in your answer, and then the expert will reveal the correct physiological or forensic truth. Here we go. Question 1. What is the underlying pathophysiological mechanism of sudden unexpected death in epilepsy, or SUDP, when specifically related to the management of barbiturates?
Death in this context is caused by the sudden absence or abrupt withdrawal of the chronically prescribed drug. This sudden loss of physiological inhibition precipitates massive central nervous system excitability, leading to fatal status epilepticus, rather than an excess or toxic overdose of the drug itself. If you missed this paradigm shift, revisit the introduction section on shared pathways and physiological dependence.
Question 2. Which set of clinical diagnostic criteria for serotonin syndrome is currently considered more specific and sensitive, largely because it heavily weights the presence of various forms of clonus?
The Hunter criteria. It is considered superior to the older Sternbach criteria for accurate clinical diagnosis because it zeroes in on the hallmark neuromuscular hyperexcitability. Revisit the serotonin syndrome section for a full breakdown of the clinical triad and the progression from mild to severe toxicity.
Question 3. A pathologically prolonged QT interval on an electrocardiogram represents a dangerous delay in which specific phase of the cardiomyocyte cycle.
Repolarization. It represents the critical delay in the electronic resetting of the ventricular muscle cells after their mechanical contraction. Revisit the QT interval prolongation section for the complete physiological breakdown of the cardiac electrical timeline.
Question 4. What specific transmembrane ion channel is physically blocked by medications in cases of acquired drug-induced long QT syndrome?
The HERG channel. Specifically, the human ether-a-go-go-related gene channel, which functions as the rapid-delayed repolarizing potassium channel, allowing potassium efflux. Revisit the QT interval prolongation section to visualize how pharmacological agents dock into and obstruct this specific structure.
Question 5. In the investigation of a suspected insulin homicide, what specific paired laboratory finding definitively differentiates an exogenous pharmaceutical insulin injection from massive endogenous internal insulin production?
The presence of massively high active insulin levels combined with very low or completely absent C-peptide levels. This profound disparity provides the unreceipted proof that the insulin was introduced from an outside source. Revisit the final section on drugs with unique modes of action to review the pro-insulin cleavage process and the forensic fragility of the sample.
Excellent work. Thank you all for dedicating your time and joining us on this highly complex deep dive. Remember, the conceptual frameworks we discussed today are designed to guide your learning, but your ultimate and final authority is the primary text. Please ensure you read Chapter 25 in Simpson's Forensic Medicine to solidify these concepts and review the specific drug tables. Stay curious, maintain your clinical precision, and we will catch you on the next deep dive.